morning.
Good morning.
Welcome to the third hearing of the Committee's inquiry into the equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to Elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respect to any Aboriginal and Torres Strait Islander people joining us today. My name's Amanda Connor, I'm Chair of the Committee. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome and thank you for making the time to give evidence today. Could you please state your name and take either the oath or the affirmation?
Of course. Cooper Smeaton, I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
Yes, thank you. First of all, I'd like to also acknowledge the traditional owners of the land in which we meet today and pay my respects to Elders past, present and emerging. Good morning, Chair, Deputy Chair and committee members. My name is Cooper Smeaton. I'm here today after making a submission to this parliamentary inquiry. Sadly, I bring the news with me of the passing of an amazing soul and loss to my community who sadly completed suicide on the 1st of October this year. This has furthered my determination to speak here today. Today I'll be dedicating my evidence and appearance here today to Kai Simon, and I extend this to Kai's family, and some of which are here today. My first point of discussion I would like to take the opportunity to speak is to the care and treatment of Kai, to which I've been told from his mother Kelly, who is here witnessing today's proceedings along with her husband and members of Kai's extended family. Kai unfortunately became another soul lost to the critically important and saddening statistic that suicide is higher in Indigenous communities and then higher again in males. Mr. Simon was treated specifically in the Hunter New England Health District between Taree and the Newcastle area. I would like to take you to his treatment in the Manning Base facility, which this was extremely damaging to the welfare and state of mind for Kai. In regards to a number of issues, a few of the key issues found here was the fact that Mr. Simon was able to escape and exit care due to being moved to a non-secure ward because of the renovations in the secure unit. Even after he expressed to his treating team that he could not control himself, he was able to escape from the non-secure unit and was found to have attempted an overdose of more than 40 individual Valium. This being his first attempt at taking his own life. Mr. Simon and his family felt that his care was rushed and that they could not express the overall care concerns due to the fact that they weren't listened to in the first instance when he was able to escape after he expressed the exact statement, "I don't trust myself." This is extremely troubling for families and I feel should be of the highest importance to fix. Mr. Simon was discharged from care from a video consultation in which he expressed he did not feel that he was happy with, nor did his parents. He was not given the committed communication from the social worker that was told to the family he would receive, and nor did his family receive any ongoing community care. The New South Wales community should know that the New South Wales health system and its people is one that works with a great sense of responsibility and genuine care for the people of New South Wales. But I believe that this is also a system that is under extreme pressure and that cracks are starting to show. If you look at the history of coronial findings that have had to include quite basic and standard operating procedures, obvious care recommendations, it's very difficult to not look past and that the fact that we have a significant care issue in the mental health sector of the New South Wales health system. Examples of this extreme pressure include the overwhelming ramping in trauma centres that should be staffed and resourced better, the lack of responsibility that has been shown in regards to the discharge of extremely vulnerable and mentally ill patients who have in turn ended their lives in the hours after presenting at an ED. and not receive critical and urgent care in the first instance. The privatisation of mental health facilities that are looking to care for a so-called stable patient because they can't handle a patient who has, prior to admission, expressed suicidal ideations is what you could call a sense of care discrimination. Mr. Simon was denied the opportunity to enter a private care facility due to the fact that a non-medically qualified receptionist informed his mother that he was not a suited patient as he was expressing suicidal ideations. This was the trigger for Mr. Simon to complete suicide and cause the most severe pain for his family and to his community. This all stems from a complete lack of resource management and funding by state and federal government alike. I am not pointing the finger at any party and or government ministers. This is a systematic harm issue that needs clear and concise discussion and response, with first being the funding to people at the forefront of where and what this is happening. Patient to staff ratios and more accountability and acknowledgement of crucial and damaging coronial and statistical evidence that shows change is needed. I thank you for your time today, and again I wish Kai a peaceful rest and that he knows his death will not be in vain.
Thank you. Thank you so much for that statement, and I just wanted to acknowledge your loss of Mr. Simon, and thank you so much for sharing that experience with us so that we can all help to make mental health care better for other people in New South Wales. It's really wonderful to have that story.
Thank you.
My first question is very broad. As you probably know, it's the job of this committee to write a report to the government with recommendations of what we could or should do differently. I think you touched on a couple of those in your opening statement, but what would you like to see as our top recommendations for change?
I definitely think the overall care aspect of patients when they present at an emergency department is looked at as a strong sense as identifying what the cause of the presentation is, and then specifically having a sector that looks after mental health. And I understand there's consulting psychiatrists and psychologists and clinical nurse specialists, but I definitely believe that when you look at the coronial findings over a wide period of time, you see that that there is a unfortunate number of patients who have taken their life after presenting in an ED and not being provided adequate care. So I believe that this should be something that is looked at, and that a responsibility after attendance is looked at by the New South Wales health system as something that they have to own.
Thank you. That's very helpful and very specific. I'll go to other members of the committee for questions. Mrs. Connor?
Thank you. Thank you for being here today. I'm sorry for your loss and the loss of the people in the gallery in respect to Mr. Simon. I wonder, could you talk a little bit more about the difficulties that family members have in being heard or being able to walk with people who are mentally ill as part of their journey, and the recognition or lack of recognition by the health system of the role of family members?
Thank you. That's a very, very important question. Something that is extremely saddening and that has been expressed by Mr. Simon's family is that exact key issue, the fact that they haven't been heard since his passing, and the fact that he was able to leave his secure care unit due to the fact that it was under renovations, and that it was chosen by that department to move him. It's extremely troubling that they're not able to be heard, and that they have been contacted for an investigation into this. But the fact is that it shouldn't happen in the first place, and I believe that there should be a departmental investigation unit that has family consultants within it. And I definitely believe that the family liaison officer, and not just one, I understand when it comes to government systems, everything does come down to funding. And it's a crucial key thing, because nothing happens without financial backing. I look at it in the way of that funding needs to be reallocated in the aspects of evidence from coronial findings, statistical evidence, everything like that. And then also having roundtable opportunities. I don't think, I understand with the committee to this aspect, I did a submission and I was then contacted and able to give evidence today, but it does in a way not intentionally discriminate people's access, because you can't expect everyone to have the ability to do a submission and then have the knowledge. It needs to be ministers, it needs to be politicians on the ground who are representing their communities who need to be talking about this. There is a massive taboo subject when it comes to suicide and mental health, and it's something that needs to be thrown out the window. The taboo needs to end, because it's something that families need to know about, and it's something that employment at the highest level and community activity still discriminate against. And it's something that families and people all alike need to know, that they can have a contact without discrimination, without being attacked or dismissed, that they need to know that there is an open access line for them to be heard.
If I could ask you a question in a different direction.
Sure.
In your submission, you raised the idea of mental health intervention teams.
Yes.
I wondered if you had any experience of them in practice, or any comments about how mental health intervention teams might make a difference in certain situations.
I personally haven't had any interactions with them, but I have read of people's interactions with them, and I think that they are gold class. I think that they are one of the key fixes to this issue within our community. To have people on the ground when 000 is called, if it requires police or ambulance attention, to have a PACER per se officer who is able to attend and assess that situation, and then be able to provide the advice to someone, and that in turn stops ramping at trauma centres, it stops ramping at ED centres, it stops the backlog of police having to guard or look after a patient while they're in ED situations. It's for me, it's a no-brainer. The fact that they are, in their name, something that is going to save lives.
Thank you very much.
Isabel?
Thanks, Chair. Thank you, Mr. Smeaton, for appearing today, and I acknowledge the members in the gallery as well behind you for also coming. I thank you for being here. In terms of Mr. Smeaton, I wondered if you had any thoughts around recommendations that we as a committee could make regarding more culturally safe and appropriate care, if and when that was to be the case.
Yeah, definitely. I do believe Indigenous medical services, to start with, I believe are doing great work. I see it on a daily basis. I actually used to live in Redfern, and I would see just even little posters and things on telegraph poles and things like that. Just simple messages, but knowing that they're out there. And I understand that there is still work to be done, but it's more going in a positive direction than it's going backwards, which I think's a credit to the New South Wales health system and then Aboriginal health alike. Culturally, I think with other cultures, I won't, with respect, I'm not of any other culture, but I do understand from having knowledge of other cultures within just general life experience that I know that there is other cultures who do have suicide and mental health as a taboo subject, and I understand that it could be harder to break that cycle. I definitely believe that if we do more campaign work and that we do more accessible work maybe in schooling. I came from a schooling background where we had one school support officer for roughly over 1,000 children. So, like, that woman was worked to the bone, and she was a godsend, but she was at her wit's end. And I definitely think that education is key when it starts with saving lives. If people know that there is health out there, that there is health access, and there is safety out there, it's one thing to have children's helplines and things like that where kids will call, but it doesn't provide genuine access in the way of ongoing care. It's crisis management, and I think ongoing care is the safety realm that's going to fix these issues.
I wanted to ask you now a couple of questions about community mental health care specifically. What are your key criticisms of the current way people experiencing a mental health crisis in the community receive care?
So if I can turn to some of the issues that were found with in relation to the passing of Kai. He didn't receive the committed communication that he was offered from the community mental health team. I believe it's an area that is probably a little bit overworked, maybe, and that they're scrambling to find their feet still quite a bit with the overwhelming pressure that they're having with the epidemic of mental health. COVID probably didn't help with that, I understand, but I definitely believe that it would come down to adding more resources into that sector. So making sure that there is accountability marks hit, maybe a after action review team that sets benchmarks for them that they have to meet, but then also having the acknowledgement that funding is required, and that it starts with what the government's going to provide. So I was told by Mr. Simon's stepfather that I believe it was about over a 4-year period that it was $60 million of funding was provided to suicide prevention. So that's roughly about $15 million a year. Some people, that's a lot of money. In a government sector, that's not a lot of money. That's, I know through experience, employment experience and things like that, when it comes to a media campaign, that's going to take a lot of your budget when it comes to $15 million because it just will. That's how it costs. So suicide prevention is going to have to be, and mental health access in the community is going to have to be something that money is thrown at until we see an improvement. And the key criticism I could have is I think it's going to start with actual personal responsibility. So if someone is allocated a patient, they need to be held accountable for that patient's care. And if they can't be, then they need to explain why. And then I think we need to look at another term of, not as in criminal charges or anything to that effect, but I think responsibility slips quite easily.
We've heard other evidence in this inquiry from the Nurses and Midwives Association regarding the allocation of caseloads, particularly in the community mental health sector, and that it was possible for, ideally someone might have a caseload of 30, which to me sounds like a lot, but that was sort of the benchmark. But that in actual reality, people were having caseloads of up to 80. So I suppose I absolutely take your point in terms of that responsibility and accountability. But if we've got a system that is currently set up whereby the staff that are supposed to be looking after and having that follow-up are being expected to manage 80 people at any one time, and there's only so many hours in the day and days in the week, what would your suggestions be around that? Because obviously you're quite an articulate and intelligent person. You would understand that
Yeah.
that's not going to. It's just not going to be possible
No,
for
it's
one
not.
person to do that much work.
Yeah, definitely.
So and having an increase in resources in that community mental health sector, where would those resources go? What would that look like? How would that work?
Well, I definitely, and I can't speak for the association, but I think they may agree with me in the fact that patient-staff ratios would need to be higher in the way of the staff ratio needs to be higher than the patient ratio. So I definitely believe that they would need better support. I think KPIs are something that are great in a corporate sector, but not great in a health sector. And I know that there is that where corporate meets community and health and things like that, but I definitely think we need to move away from corporatising, for lack of a better word, the health sector, and bring it back to the fact that these are people managing people who have complex needs. My mother was a disability mental health caseworker, and she was answering the phone at 2 a.m. in the morning when she wasn't getting paid to, because she has a heart. And there was many times where her boss would have to say to her, "You're not allowed to bring them to your house for Christmas," because it's, first of all, not appropriate, and second of all, you need to be able to respect your own boundaries and look after yourself. So I understand the fact that they need the resourcing and the more staff, but also more assistance, and I think the way of looking at it is maybe going to those people and asking them what they need, but then also putting in place operating procedures where they can reach out and say, well, maybe this person needs more of a complex support system, or we need to refer on to somewhere else that can support them more with a more ongoing care, because people are going to need 24-hour care sometimes, and it's not opportunistic that it can happen with a community care point of view, even if they want to be out of hospital care. So I understand the point that it's going to be a hard road, but I definitely think that if people look at it from the perspective of they attend to this in a way that opens it up to a more broader aspect of care, with more resourcing in funding, more resourcing in staffing, and even just better access to facilities. I think maybe even looking at opportunities for use of the private sector, if it could be looked at, where government funds situations within the private sector aspect of care, we could do better on that. Psychiatrist appointments and things like that, they're extremely expensive, but I know that they do make such a change. And I know that through personal experience, and I definitely think that if we could have a more look at more psychiatric resource management in the community, I definitely think there could definitely be good change.
Thank you. We've come to 10:30 already.
Oh, wow.
Thank you so much again for the time that you've taken to give evidence today, and the Secretariat will be in touch with you if there are any questions on notice.
Brilliant. Thank you so much for all of your time. I appreciate it.
Thank you very much for
Thank you.
Thank you.
Good morning. I'd like to welcome our next witness representing the Dementia Law Network. Could you please state your name and position title and take either the oath or the affirmation?
Fiona Comfer, I'm the co-founder of the Dementia Law Network, and I'm also Associate Professor at the University of Sydney and a clinical neuropsychologist. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
Thank you. I'd also like to acknowledge the traditional custodians of the land which we meet today, the Gadigal people of the Eora Nation, and I pay my respects to elders past and present. And I'd like to thank the committee for the opportunity to present evidence on behalf of the Dementia Law Network. It's estimated that dementia currently affects around 400,000 Australians, and of these, around 25,000 people have younger onset dementia, where symptoms occur before the age of 65 years. Often people think dementia only affects older people and is associated with memory problems, but dementia is an umbrella term of which there are a number of different subtypes. In the younger age group, frontotemporal dementia is as common as Alzheimer's disease, and it is characterised by changes in behaviour and language. In people who develop behavioural changes, these can be misperceived as potential criminal behaviour, and what we use the term as criminal risk behaviours. That indicates behaviours which put people at increased risk of interactions with the police or the legal system. We established the Dementia Law Network around a year ago in recognition of the lack of knowledge around issues at the intersection of dementia and the law, and in particular understanding around these criminal risk behaviours. We found that there was a dearth of research in understanding why these criminal risk behaviours emerge, and importantly how we can better manage them in the community. The aim of the network is to bring together researchers, clinicians, legal practitioners, people with dementia, their families and the broader community to advance knowledge at the intersection of dementia and the law. We're currently working closely with stakeholders, including the Ageing and Disability Commission, Legal Aid, Dementia Support Australia and Carers New South Wales to understand these issues further. And I'm grateful for the opportunity to present some of the work from our stakeholder workshop that we held in June, as well as work that we've been doing at the university to understand these issues further. Thank you.
Thank you very much. Firstly, just wanted to acknowledge the level of consultation and work that went into the submission that you're presenting, and understand you're representing a number of people today, and that's really appreciated. It's very valuable evidence.
Thank you.
Having a look at the workshop report, you've got several pages of recommendations that go across a number of sectors. So I appreciate the written submission, because I'm sure we won't have time to go into all of them today. But I was hoping, this committee will go forward to make recommendations to government. If you had to pick what the most urgent priorities in terms of your recommendations are to implement, could you speak to those?
Thank you. There's really two areas of really urgent need in this space around dementia. The first is really around early recognition and diagnosis. So we find that in the general community, as I mentioned, there is a lack of understanding that behaviour changes can present as dementia, and also that dementia affects people in this under 65-year age group, and that can really lead to this inappropriate criminalisation. It's not only we see this across a number of sectors, so the general community, but also health professionals, so that we know that there's at least a 3-year delay in diagnosis from when people first start presenting with symptoms to when they are ultimately diagnosed with dementia. And this is particularly the case when it is younger onset or these behavioural changes. Around 50% of people get an inappropriate diagnosis of a psychiatric condition prior to being correctly diagnosed. So we think there's a real need in terms of upskilling clinicians in terms of being able to recognising these issues further, better education in terms of how to diagnose dementia, and ensuring that people have access to skilled clinicians when these behaviour changes present. Obviously, this also involves educating the community so that people are aware if they notice behaviour changes in their loved ones or people around them, that should really be the trigger for medical investigations or for the follow-up in terms of health. The other aspect is obviously in terms of how we manage these changes. And there's a number of recommendations that we've made. We know that there is a role for police response in terms of when people do have severe behaviour changes, but that police need to be better educated in terms of how to better manage people living with dementia and how to de-escalate these situations. So our consultations already with police has identified that they have very minimal training in terms of these issues, in terms of being able to recognise dementia and understanding how to move forward. The other issue is that we see that clinicians find it difficult to understand who to refer to or what services are available in terms of managing these behaviour changes. So something that came out of our stakeholder workshop was that even though these were very skilled clinicians who are working directly in this area, they even felt confusion in terms of who they could refer. Part of this is because of this arbitrary 65-year age cutoff. So if someone is below the age of 65 years, they may be more suited to the NDIS. If they're above the age of 65, they're more suited to my aged care. And this arbitrary cutoff makes it very difficult in terms of knowing who to refer to. So clinicians really expressed to us a need to have a clearer referral system in terms of when they notice these behaviour changes, who can they contact to help to manage them.
Thank you. That's really helpful. I'll go to other members of the committee for questions. Mrs. Carr?
Thank you very much for being here today, and thank you for the submission and also thank you for the addendum, the workshop report. I notice, I think the observation that behaviour that is dementia-driven presents as criminal and therefore gets a criminal response, and the recommendation that this could be addressed by more training of first responders. I wonder if you could provide some comments around who could provide that training, how long that training might take, how often it might need to be refreshed, and also perhaps would the training be sufficient? So if somebody is engaging in violent criminal behaviours, they have no will to do that, but the act is there, whether there also needs to be a typical police response for the safety of that person and other members of the community.
Yes, so absolutely this is a very complex and complicated issue. So we need to manage both the best interests of the person living with dementia as well as the safety of the community more broadly. In terms of having an appropriate police response, one of the things that's been identified today and also in terms of the terms of reference is PACER, and that was something that came out in our workshop report as something that was extremely valuable. So where there is sort of serious violent behaviour or other serious concerns, having a mental health professional as part of the police response is really essential to ensure that the person is appropriately managed and receives health response rather than a legal or criminal response. Our understanding is that this has been really successfully piloted in certain areas, but that the rollout has been patchy and in terms of the resourcing around this. So we think that absolutely there's a need for a police response, and PACER is something that really should be expanded and ensure that it's available New South Wales wide. In terms of the training, that is really something that our network is focusing on in terms of what would be necessary and sufficient. So there are aged crime prevention officers as part of New South Wales Police who work specifically in aged care, in aged populations. But as I mentioned, in this younger onset, there's this difficult delineation between under 65 and over 65. And I should mention that in Aboriginal and Torres Strait Islanders, we should really be thinking about over the age of 50 in terms of onset of dementia. So again, this arbitrary cutoff can lead to some difficulties in this space. But certainly having specialised people within the police who are having more comprehensive training and then potentially more widespread training for all police officers. I think many of the things in terms of de-escalation in these sort of situations are probably not unique to dementia, but would also be appropriate for people with other types of cognitive impairment or mental health. And so really being able to skill police so that they feel confident in these situations and to defuse situations is really important. And that's also something that has come out of interviews that we've done with carers and family members, that often they've found when police are called, it can make the situation more complex and more emotionally charged. So finding ways to really minimise that and diffuse the situation is really important.
I'm just wondering, given the evidence you've given about the relatively high rate of misdiagnosis, or at least early misdiagnosis, and the difficulties of people in the community being confronted with what they see as a violent situation, I mean, how easy would it be at the point of the 000 call or the dispatch of the police to be able to know whether a team was going out to deal with the person with dementia or other cognitive impairment, or somebody running through a shopping centre with a knife?
Yeah. That's a really important question. So I think there's two groups of populations that are affected here. There's certainly people who don't yet have a diagnosis, and that's obviously even more complex because we don't know the etiology. One of the red flags that's emerged in our research is where this is new onset criminal or apparent criminal offending. So if someone has otherwise not behaved in this way and this is out of character, that would be more of an indication for dementia. But one of the other things that has come out is that even with people with a diagnosis of dementia, people don't necessarily believe it because the person doesn't have memory problems. So there's a real stereotype of what dementia is in terms of it only affects older people and it only affects memory. And so then if police or security guards are called and the carer, the wife or the spouse or family member says they have dementia, please don't arrest them, please don't charge them, the police might say, well, actually, they can remember exactly what happened and they're far too young, so they can't possibly have dementia. So there is that issue in terms of even for people with diagnosis of dementia, that, yes, there's various ways that it can still impact on them and their families.
So if somebody with dementia, diagnosed or undiagnosed, is in a public place with a knife, police are called, let's say that person is arrested. Now, presumably there's no criminal charges or at least conviction because there's no mens rea. So what support and what follow-up is there for that person who's had that contact with the criminal justice system?
Mm-hmm. So this is where some of our case studies that we're doing at the moment is really important, because we're actually looking at specific situations of what happens to people. There is still a group of people who will be charged and ultimately will go to court and will usually be dismissed under Section 14. But
so can I stop you there? Why would there be a charge if there's no mens rea?
So I can't comment specifically on any individual cases. All I can say is that we have examples from legal aid and from our links with specific solicitors where it has been where it has actually led to charges being laid. I think it is probably more likely in the situation where the diagnosis isn't definite, and so that comes to light through the proceedings. Mm-hmm. So yes, hopefully that answers your question.
I find that confusing. I'd be interested to know more about that.
Yes,
because unless it's strict liability, you need the mental competence to be able to complete the crime.
And that's exactly why we're keen to look at these case studies, so that we can understand better the trajectory of individuals, and also identify potential off-ramps where things could have been done differently. I guess the other thing I'd like to mention in terms of your particular comment is that the types of behaviours that we see are very diverse in terms of their seriousness. people with dementia showing these violent behaviours are very rare. And what we see more commonly is that it's people showing disinhibited behaviours. So they may, for example, approach children that they don't know, or they may be in a shop and have taken something in their pocket and forgotten to pay, for example. So there's issues around trespassing or shoplifting or swearing and those types of things. Often what happens at the moment is the burden is really on the family members to manage those behaviours, and what we hear from family members is that they just keep the person with dementia at home to minimise these risks. I just wanted to mention that these sort of very violent behaviours, or for example someone walking with a knife in a shopping centre, is very rare and unusual, and it's more these sort of disinhibited or inappropriate behaviours that can occur.
Well, I suppose that's an even better example, because I suppose what I was exploring was to the extent to which this contact with the criminal system actually operates as the red flag that this person needs treatment and support, and whether that then acts as a gateway to receiving that treatment and support.
So I don't think that we have any good data at the moment on that, because the data that we've collected to date is on people who already have a diagnosis of dementia. There are services that are available in terms of managing behaviours. So some that emerged from our stakeholder workshop were the Dementia Support Australia Dementia Behaviour Management Advisory Service, where they can come in and give advice or suggestions on how to manage through interventions these behaviours to minimise them occurring, and also the Older Persons Mental Health Service, which again there was some discussion in the workshop in terms of who's eligible for that. Is dementia falling under a mental health service, and do you need to be over the age of 65? So I think that seems to vary across different local health districts, but certainly those services have been found to be very useful for people in terms of managing the behaviours in an ongoing setting.
Thank you.
Thank you. Are there any questions from the government?
Yeah, thanks, Jo. Do you want to...
Yeah, I'll jump in first. Thank you very much for coming today, and it's a very helpful submission. Just go to page 4 with recommendations. I'd just like to have a discussion, if I could, with you, or ask some questions around what's paragraph 27. It's not recommendation 27, it's paragraph 27 and paragraph 28. The position at the moment is that when there's an incident or a potential incident, we have the police as the first responders often going and responding, arising from often a 000 phone call. As you would be aware, in some other jurisdictions in Australia and overseas, that's not the case. There is travelling along with them or intervening with them are a group that would have, or within that group, a level of expertise to assist in dealing with the matter before them. But they may well have very limited information, but are drawn into dealing with an incident or a particular incident. If we just look at the moment where there's just the police, because we haven't moved to the next step, and that may arise or may not arise from this inquiry, we'll wait and see. But with the police, would it not be the case that even with some improvement in the training, if we could try and get to that first, of them being cognizant that in intervening the person may potentially have a mental health condition, it's even a further step to be able to expect them to contemplate the person may have dementia. Do you know what I mean? That, in other words, we are probably at the point of not getting them or not having them at this sort of level of base understanding. In a sense, the dementia is a sort of almost a specialisation within that. Do you think that that's potentially problematic in trying to go straight to that, as opposed to getting this elevation of understanding around mental health and having dementia fall within that as a broad, overarching sort of explanation of the person's potential condition?
Yeah, I think that's a very important question, and it's certainly something that came up at our stakeholder workshop in terms of, is the expectation for police to diagnose dementia on the spot too high? Obviously, that is not what we're expecting people to do. I think part of it speaks to a broader community awareness, which includes first responders such as police, paramedics, security guards and so forth, in terms of how dementia presents and the diversity of it. The other thing that I mentioned is I think certainly some of the ways that people can approach people with mental health and cognitive impairment and dementia would hold across the various different groups. So you don't really need someone to be diagnosed with dementia versus autism, for example, or some sort of intellectual disability to decide the best way to respond. In many cases, the best way to respond would be similar across these different conditions. And so I think we're not talking about specifically diagnosing dementia on the spot, but really thinking about when you're approaching people who may be behaving in a way that is out of character for them, how can you approach that in a way that doesn't escalate the situation further? And are there strategies that we can give police in terms of de-escalating and defusing the situation? That may, for example, be, if there's family members there, speaking to the family members, getting them involved, so on and so forth. So, and certainly our network, that's why we really want to work. I'm an academic, I work in research, so we don't have some of the answers to these questions yet. We think it's really important to work together with police and other first responders in terms of understanding what their existing protocols and training are, and then how can we as clinicians inform that training for them to be best equipped in these situations.
No, I think, I wasn't intending to suggest that the police diagnose, but rather, I guess, you answered my question that within the I'll use the word spectrum of potential mental health manifestations, that's where we need to really lift up the capacity of that understanding. The matter of de-escalation, it's been raised by other witnesses and in other submissions. Just a little bit curious in that, as far as I understood, a key element or a not insignificant element of the training of people going through the police academy is this teaching and mentoring around de-escalation of a matter, whether or not the person has a mental or potential mental condition or not. The sort of use the vernacular Rambo style of dealing with issues, as I understand, is in the past, and which to the extent that did happen was obviously a very good thing. I thought there was a fair bit of teaching and training of police to, in the first instance, see if they could de-escalate the situation. Was that not something that was raised in the workshop you had about their existing training? Because you need to understand, because that de-escalation may not be trained in the context of dealing with mental health manifestations or matters to deal with. But I thought more broadly speaking they were trained in that.
I obviously can't speak to what the current training that police have. Certainly in terms of our workshop, we had a number of representatives from New South Wales Police there, and they were all very open and welcoming to additional training and additional resources. Again, one of the things that came out from those discussions is that they didn't really know what to do if the person presented with behaviour changes. And the family were there saying this person has dementia. Typically, people are taken to the emergency department and then left for the health system to sort of manage in those situations. They won't. Rather than being taken to the police station, for example. And they really expressed that they felt that was inadequate in terms of how they should respond. So they were really asking us, what should we do in these situations? How should we best respond? And what are the next steps? So,
I think that... Can I interrupt and say, did you have any preliminary responses or answers to those questions from them?
So one of the things that did come up was that for other issues, there are sort of hotlines that you can call. So, for example, 1-800-RESPECT, which then gives you the appropriate services and sort of a flowchart or pathway that you may be able to follow. And that's available for people in the community, but also for, people working in the sector. And that really came out as something that not just police but also clinicians and other professionals that were there thought would be very useful, so that when you're in this situation there's just a single number that you can call, and then they will help you navigate through the health system in terms of what services people would be eligible for in the community or through the health service and so forth. So certainly a centralised place that people can call in terms of what to do next in this specific situation was really highlighted as a potential thing that the police thought would be useful.
It's very helpful, thank you.
Thanks.
Are there any further questions? Yeah,
I'm
go
happy
ahead.
to take one if you don't have
Go
one.
ahead.
Okay. No. Thank you, Dr. Comfer, for your appearing today, and also wanted to acknowledge the work of your colleague as well, obviously, who's helped with preparing the submission, Professor Rees.
Yeah, Nola Rees from
Nola
YouTube.
Rees, yes. Yeah, thank you. In terms of the research that you have undertaken, in the submission it sort of underlines that the cohort that is reflected may be somewhat of a limitation to how that data is interpreted. I just wondered if you could speak to whether or not there is any further research to be undertaken, or what caution needs to be applied when interpreting the data.
Yes, thank you for that opportunity. To our knowledge, there hadn't been any prospective studies looking, not even in Australia, but also internationally, in terms of how common these criminal risk behaviours are, what some of the predictive factors might be, so that we can recognise people who are more at risk. The first piece of work that we've done to date is with 150 people who were all participants in our research at the University of Sydney. So we do tend to see people who are willing to participate in research, who have the capacity, and from specific socioeconomic backgrounds. They tend to be more metro and so on. We're very keen to roll this out more broadly. So we've got ethics approval to recruit nationwide through, for example, Dementia Australia, through social media, to try and get a better sense of what's happening regionally and remotely. In terms of our analysis, we didn't find any specific demographics that predicted these types of criminal risk behaviours. So we looked at things like age, sex, education and so forth, and they weren't predictors. The only predictors that we found was having a diagnosis of frontotemporal dementia, and also having a longer disease duration, which may be that people who progress more slowly are living in the community for longer and then have more opportunity to interact in public settings. But absolutely, we don't have very good data on, for example, people from Aboriginal and Torres Strait Islander backgrounds, culturally, linguistically diverse, regional and remote Australians, lower socioeconomic groups. We know that there's some aspects that are predictive of people being in the criminal system more broadly that may also apply in this particular space. So that is something that we're working on investigating in more detail. But yes, at the moment we don't have more data on that more diverse population yet.
Thank you. And just a follow-up, very quick final question with the time we've got left. In your submission, it mentioned in paragraph 19 the consequences for people with dementia after contact with police or authority figures, including being scheduled in psychiatric wards, which I found quite interesting. In terms of the 150, was there any that were more highly represented? Was there was this something that everyone had sort of was there any patterns, I suppose, in that data?
So of the people who showed these criminal risk behaviours, around 20% led to interactions with police or other authority figures such as security guards or paramedics or so forth. In the vast majority of cases, it was really managed outside of the legal system or outside of the health system. So, for example, they were banned from their local shopping centre.
Which would still have consequences on someone.
Absolutely still has consequences, not just on the person with dementia, but also their family. So, for example, the spouse said, you know, I can't do my groceries anymore because they can't be left at home and I can't go to the shops. So, you know, there's very simple practical implications. In terms of being scheduled in psychiatric wards, from memory, that only happened in one case out of our 150, so it's relatively rare. But again, it is something that came out of our workshop was that for people with severe behaviour changes, there is a degree of recognition that it's inappropriate for them to be in custody, but it can be difficult for them to be living in the community. There aren't residential facilities that will take people with these severe behaviour changes because of potential risk. So there's a couple of very specialised residential facilities Australia-wide, I think 6 maybe off the top of my head, but otherwise people won't take someone with dementia with these severe behaviour changes. So unfortunately, often they will end up in hospital for extended periods of time, as that's really the only place where they can be managed.
Thank you.
Thank you.
Very helpful.
Thanks so much for the time you've taken, not just to give evidence today, but in preparation of the submission and holding the workshop. We really appreciate it. And the Secretariat will be in contact with you if there's any questions on notice.
Thank you. Thanks for the opportunity.
Congratulations on the great work. It's very good.
Yeah, all the
Thank you.
future research, yeah.
I'd like to welcome our next witnesses representing the Police Association of New South Wales. Could you please both state your name and position title and then take either the oath or the affirmation?
My name is Kevin Morton, spelled Morton. I'm the President of the Police Association of New South Wales. I'm also a serving Sergeant of Police with 35 years service. And I'll be taking the oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you.
My name's Tony Bear. I'm the Manager of Relationships and Strategy for the Police Association. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Would you like to start by making a short opening statement?
Yes, I've just got a short statement. I'd like to thank you for the opportunity to address the parliamentary inquiry into equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. I've stated many times that police are the 24/7 problem solvers for the communities of New South Wales. And when someone calls, we don't have the luxury of hanging up. But there comes a time when the reliance on police to fix the downfalls of other government agencies becomes untenable. Responding to mental health incidents is one of those areas. Police are not mental health clinicians, and more often than not, the mere sight of a police officer's uniform will only exacerbate a person dealing with a mental health issue. The use of police officers to prop up a failing mental health system not only affects those involved in the incidents, but affects the broader community, as we see more and more police officers consistently taken away from their core duties of protecting their communities. Thank you.
Thank you. Thanks very much for being here today. I think the voice of police officers and their representatives is really important for the kinds of questions that we've been asking.
Yep.
I've got a few of my own questions. The first one is that I'm aware that some New South Wales police officers have been sent across to the UK to have a look at perhaps an alternate model of responding to mental health incidents. Is it something that you're aware of or you'd be able to speak to?
Yeah, absolutely. I'm not aware of whether those police officers have returned in relation to it, but they've been sent over there to review what the UK has in place and what has also been in place in Scotland for some period of time, called the right care, right person model. And it was a decision made by the Premier about a month and a half ago to see how police involve themselves in mental health issues in the UK. In essence, it says that it is not our job to be attending these mental health incidents, and that's the model that the UK police are looking at implementing.
Thank you. And my second question is, it's come up in a number of evidence from other bodies and individuals, the question of what training police actually have with regards to mental health. What is the current training that's provided? That is more an operational question that you'll have to ask the Commissioner in regards to that. We did have a mental health training program that the police did, and it involved also the PACER program as well, but I'm led to believe that has now ceased. Okay, thank you. Yeah, Mr. Fang.
Thank you for appearing today, and it's a nice segue actually, your previous comments. I wanted to ask you about the PACER program. We've heard much about how PACER was initially rolled out by the previous government. I was interested, one, in your thoughts about how you felt that supported your, frontline members, and two, how you feel about the program not receiving an increase in funding in the recent budget.
Look, the PACER program's a good initiative, adds to policing, helps our members on the front line. Our point is that even given that funding, which was good, and changed the way that police were able to go to a situation and diffuse, otherwise avert those type of incidents. We have now come to the point where it's just with community sentiment, with the way that the amount of workload police officers have day to day, our call is now that it's time for health and others to take the ball up and to run with mental health, and police should at the very least be the last of the last resorts to mental health incidents.
Fundamentally, PACER still requires a police involvement in that initial care. And the program, as Tony said, did have some positives to it, but we are a 24/7 organisation, and the program, you may only have that person with you for 8 hours of the day.
I guess it's a question though whether that 8 hours of the day made a difference if you were across situations where you were asked to attend for any number of reasons, and you're right, police are the 24/7 problem solvers in our community, along with many of the other frontline workers that we have. Whether it played a beneficial role, do you have any first-hand accounts from people within your organisation that might be able to either support or give us an idea of how it made a difference, and then what you think the difference would be if we didn't sort of have that program, but looked more towards removing police from that mental health first response, because I think that the community very much values the fact that the police attend all those difficult situations because of the value that you provide to the community and surrounding the incident.
Look, as we stated, the PACER made some good inroads into helping frontline police understand. I think there were 4 trial points to PACER, and during those times it was beneficial. But again, the work that needs to be done on a long-term basis, and which we currently see happening within the metropolitan policing in the UK, where although health didn't want to take over to begin with, are showing strong gains in the way that incidents are being dealt with. So, it's although beneficial, and if police were to continue to have to do it, it would be a tool that we talk to government about moving forward. But due to our call is at this point in time is to move forward with a model that has little to no police involvement in it.
Yeah, I guess I'm just trying to rationalise in my thoughts the proposal that you're putting forward, which is effectively not including police in that response. But I think the community themselves often feel as though there's value in having police there. It's reconciling the two, and so given that there was no increase in PACER funding in this recent budget from Labor, what do you see as the alternate when the community themselves are seeking to have law enforcement available, if not for nothing else, and to protect the other frontline workers who are there, the community who are rightfully concerned, but also protecting the person themselves who is at risk?
If I may add, I disagree with you in regards to your comments in regards to the community. We will always respond to those incidents if the mental health crisis team believes that we need to attend, or if ambulance officers require us to attend, and that is our role, is to protect them whilst they deal with this matter.
Yeah. So you might have misinterpreted that. Then,
When there's a violent incident, police will be called, and I think that's sometimes in this place we see police used as a bit of a punching bag for incidents that will never stop being police incidents. And I think that's where you're going with it. They will never stop. If people are called 000 and there is a person who is in a public area being violent, then police will need to be the primary agency. What we are saying is that on occasion, and a lot of occasion, the primary agency should be health.
Yep.
And that sometimes when police are called, the mere fact that police are present can escalate the situation.
Yeah.
Yeah. And you know, on that point is that you know it's this two houses here and government that sets the legislature for what police do, and never should the frontline worker, whether they be health, whether they be corrections, or whether they be police officers, be held responsible for merely enforcing the laws of the day.
Thank you.
Can I just ask a brief follow-up, and then I'll go to the government? I was interested in your perspective on the South Australian Mental Health Co-Responder program, which, if you're not aware, it's a collaboration between Central Adelaide Local Health Network and South Australian Ambulance Services, where mental health emergency calls go primarily to a mental health clinician who responds in person with a paramedic. And of course, those clinicians have the opportunity to ask for police to co-attend if they think it's necessary because of an individual risk assessment of that person with the knowledge of their mental health medical records. Do you think that sort of model would be more agreeable for New South Wales Police to work in compared to what we've got at the moment?
Given the opportunity, especially with escorting those with mental health issues, schedules and so forth, they shouldn't be put in police vans, they shouldn't be put in police cars. They should be transported to their hospitals and so forth in a you know, respected way. Police vans aren't for those with mental health, but unfortunately in New South Wales, other agencies for a long time have cost shifted, have moved towards the 24 hours, 7 days a week worker, which is who has the resources. And look, I'm not here to put any
Cast aspersions.
on other frontline agencies such as the old Department of Community Services or Health or whatever, but across this state, which is so wide, you know, you're talking about places like South Australia and others that are so much smaller than this state, and even England. I mean, how many times does it fit into New South Wales? But you know, in country areas, so this isn't just a problem with mental health in the city. It's everywhere. It doesn't. Unlike a lot of other crime, or this is not crime, but like other crimes that we dealt with, it's socio-economic in basis, a lot of crime, whereas domestic violence and mental health, there is no boundaries. There is no, you know, way of saying that, oh, because you live in this area or you live in that area, it's going to not be effective. So mental health transportation in particular with that is exactly the right way of going, where you would have health and those that are on mental health with the teams that crisis teams and ambulance. But unfortunately we've had those MOUs in New South Wales, and simply because the ambulance aren't resourced, or the health aren't resourced, or whatever. And this isn't the last 12 years, it's not current. This is 40, 50 years of underfunding across all sides of government, where they need to be effectively resourced. Health needs to be effectively resourced. Ambulance needs to be effectively resourced. We're not pushing back on these things to try to cost shift back to anybody else. But if you're going to make recommendations out of a committee, there've got to be recommendations that are able to be put into place with the right funding, because otherwise we're going to sit back here in 5 or 10 or 15 years' time talking about the same problems, because we all know what the answer is. The answer is for the right people with the right training and the right time with the amount of resources that are needed to do the job.
Thank you.
Can I just ask one follow-up question?
Sure.
That's okay.
I'll allow one question
Yeah.
and we'll go to the government.
Just one question. How much information do police have when they go out on a call? How often do they know ahead of time that there's a mental health issue that they're dealing with, as opposed to somebody's exhibiting troubling behaviour?
I was going to say the South Australian model is good. Tony's explained reasons why it'd be difficult to have that in use, but the initial information from treating practitioners would be essential. What we have basically is any interaction or any that we've previously had with that individual that may or may not have been recorded by the police that dealt with that person, or the information that comes in from that person that has called the police on behalf. That is it in a nutshell.
We are not privy to health records or anything like that, and to be honest, I suppose neither should we. I'd imagine for privacy concerns. I know that we wouldn't want our members to have their privacy going across government. So apart from the initial information and what family or share with the Triple O operator, that's it.
So if you get a call, 60-year-old man naked walking past a school playground, no name, you just don't know anything.
Police officers are fairly cluey. We've been around for a long time. We know when we're going to a mental health issue. The trouble is that you can know you're going to a mental health issue, but we don't see mental health when a person is carrying a weapon, who is next to 5 other people, or needs to be kept within a area. That then becomes another ball game altogether, and that's the problem. That when it gets to that point, when police must act on the training that they're provided, and so be it. And I think the public expect that to be preserve life and property. That's our oath of office.
Thank you. Thanks, Chair.
Thanks,
Mr. Bell.
Chair. I'll just continue along with that line of questioning in terms of that, that oath that you've taken. With the PACER model, which we've heard about, I'm just keen to understand how that attendance varies if and when it is the case that someone has a weapon.
Oh, the PACER, that they're not involved in those.
So if it's a mental health, someone's in a mental health crisis, but they've got a weapon, as say a knife or something, and that's what how the emergency is called in, automatically the health clinician is struck out. Is that correct, or they won't respond?
They don't have the training to be in that front part of that line, so they may well be at the incident, but until it's de-escalated to a point where they can safely be involved, then yes, they could be involved. But as you would realise that once it gets to that height part, the de-escalation part of that is rare.
Okay. And in terms of the training that you do have around, is there training around de-escalation? Does that cover processes to de-escalate someone when they're in distress?
On several accounts, we have mental health training, and we have other programs called the MHIT program that was discontinued.
That was discontinued,
But we have other training, core training. Most importantly, we do have what we call the circle of
Use of force.
Use of force. So number one, use of force is in the mouth, and then you have a circle of, and what we have, it's a circle because you go forwards and backwards on it. It's not one size fits all. You may take a taser out, put it back in, continue to talk, assess. You may need to have one may need to have a firearm out, one may need to have a baton out, but it's never, once you've pulled something out, that you've got to use it. It's always using your communication to get the best results for everybody in that circle of...
Without a doubt, the use of communication skills for any police officer is their most important weapon that they have. Unfortunately, when we get to mental health incidents, the mere fact that we are there in uniform with a person that is seriously and critically having a mental health episode, again, like I said before, it just exacerbates the situation, and no amount of communication skills, even for the best of officers, may not be able to de-escalate that. May not.
And so just on that, you talked earlier about this UK model. I'm keen to understand from your perspective, what are the alternatives to PACER, and what would be, in an ideal world where there's infinite funding and no demarcation issues about who does what?
Well, it starts at the very beginning, obviously, with the patient being able to get sufficient care, being able to call up and get that opportunity to speak to their treating practitioner. We have incidences, and I'll give you a very simple example, where we've decided as a collective to put these people back into society because quite often that is what they need to get that care. Unfortunately, sometimes they have to have medication and they'll be put under a community treatment order. And that requires them to attend the local pharmacy and pick up their medication for the week. Now, should that person not attend, the chemist makes a call to the doctor, says that Kevin Morton hasn't turned up to pick up his meds. The doctor calls the police. That is not a police matter. But we're getting involved in that lower level of interaction with mental health patients. And that's what we're saying, that is not our job.
So police will be called if someone's breached a CTO?
Police will be called saying, Kevin Morton hasn't attended to pick up his medication. Can you go around and do a welfare check on him and make sure he's okay?
Now, who should be called in that instance, from your perspective?
Well, in a perfect world, as you suggested, it should be the doctor's decision as to whether they should activate either themselves or a mental health crisis team or some other resource other than a police officer.
It's a health matter. Someone's not taking their pills. It's a health matter. At this stage, there's no evidence on the call that they're violent or threatening violence to themselves or anybody else. So, these are the kind of things that can quickly escalate when someone knocks on the front door, someone hasn't taken their medication.
Yeah.
They're going, they see police and suddenly they see something else. It's not a police officer, it's, someone else going to take them away. And that escalates the problem.
Yeah, so you mentioned previously that you have had, or police rather, have had MOUs in New South Wales previously regarding mental health response. I'm keen to understand how they worked and if they didn't, or what's happened there.
So, especially in the bush where hospitals were not enough hospitals were designated to be mental health drop-off spots or designated hospitals. It could take up to 2 hours, 3 hours for them to be transported. Hence, one part-time ambulance in that country town, so they revert to police. The biggest problem is in schedules that they have, a doctor will automatically just tick the police to go and do it because it's easier and quicker. But they've got to say that the person's likely or he has a fear that the person's going to be violent. These are ticked because, Chatswood Police might have 7 cars working that day and the ambulance are sitting out the front of North Shore Hospital, and they want them either brought to a privately funded or other institution. And it's just easier to hit the schedule, tick police, it's faxed through to the police station, and the police are off. Faxed, it wouldn't be faxed these days.
They don't fax anymore.
Sorry, I it's been 12 years since I was a police officer, so. But you know, these are the kind of things that you're talking about. Where I was talking earlier on about the way that it can be manipulated, so that the police are used as the primary agency, where it should be a lot harder. There should be a lot greater threshold, because quite frankly, our members are burning out. Our members are upset, traumatised by putting people into police cars or causing to have a physical injury to the people. You know, we don't want it, and nor do we want the fallout when things ultimately go pear-shaped.
Kevin, did you have anything to add?
No.
No. I'm keen to understand as well about this issue, because I had a question about the scheduling and what occurs there. So is it the case at the moment that when someone's scheduled, it may just be police that attend and pick them up and take them?
Oh, I think 90% of the time.
Yeah, I would suggest
And are
that
there,
it's,
so are there
it's 90%
statistics
of
around
the
that?
time.
90%.
Under
okay.
the schedule, the threshold is a lot lower than what the ambulance have in regards to taking that person for a mental health assessment.
Okay.
The crisis team should be attending those in the first instance every time.
So the crisis team, if one exists?
Yes.
Yeah. And are there crisis teams that, you know, your police work with or have a relationship with?
I couldn't accurately answer that question now, because, again, there is such a reliance on police to do this. I think there are a lot of small organisations out there, independently funded, that do a fantastic job. I have a cousin that works in one up at Port Macquarie. Again, it comes down to funding of what her and her team tries to do in this mental health space. But ultimately, it becomes a reliance on the police.
Especially for a schedule. I think mental health and the people working in mental health do an outstanding job with what resources they have, to be honest. It's hard. I go back, and I'm sure the committee has gone back in time, and when I was working at Balmain in the early 90s, we had Roosevelt Hospital with 6 or 7 lock-up wards. We had the hospital at Ryde. You know, there were plenty of hospitals for mental health, and then the Richmond report was done, and you know, halfway houses and in community care. Now, I'm not saying which is right, wrong, or indifferent, but funding over that period of time has gone from here and it's down here, and there are more people, there are more population, and it's one part. And I will say this straight out: mental health is an epidemic problem. Now, whether it's been brought on by any number of different things, stress, whatever it is, drugs, or whatever it is, it's a problem, and it's got to be dealt with. But you're asking the wrong people to deal with it, because it's simply easy to do. It's simply easy to pass it down to police, who are 24/7, who are there to pick up, you know, kids that need to be picked out of places for the Department of Community Services, for transporting of prisoners when there's no corrective services, and for scheduling or to go to mental health incidents. And quite frankly, our members are stretched. Our members are stressed, and they need other agencies to be funded to do what there's not their job.
Do you have any questions, or am I keep going?
I understand
one,
Mr.
but,
Fang's
yeah,
got a
go-
question,
yeah,
and
after.
then we'll come
Through
back
you,
across.
Kelly, after you.
Thank you. I just wanted to, I guess, find out
I have lots more.
what representations you've made to the Minister, and I guess not just the Police Minister, but obviously there'd be representation to Ryan Park, the Health Minister, and to Rose Jackson, the Mental Health Minister, about your concerns in relation to your members and what the government has said to you about how they're viewing the concerns that you're raising.
This, for our membership, has come to a head, and we made quite an issue of it several weeks ago. It was the first time, and I applaud the Premier for this, the first time that I ever saw anyone act so swiftly in finding out what happens overseas, in sending 2 senior police officers overseas to see if we can do it better. And again, like I said, I applaud him for those actions, because I've never in my 35 years seen government act that swiftly. Now, I'm very keen to see what those police officers bring back. But I'm sure as we do, as we move into the future, then I believe this government is definitely listening to ours and my members' concerns.
Listening is one thing. What we will do is see what the outcomes are.
Yep.
And as I said in my previous evidence, is are we going to be here in 3 years, 5 years, 10 years' time asking the same things?
I'm just curious as to, obviously, you know, it's one thing for the Premier to be listening, but the ministers involved, and you know, I guess in this area you've got 3 ministers. You know, Minister Catley, you've got Minister Park, you've got Minister Jackson. All 3 of them need to be, I guess, on the same page for your concerns to be actioned. Have you had the opportunity to meet with those ministers? Have you had the opportunity to get some commitments from them around how they're viewing your concerns, other than just another review, which is what this government seems to be very good at doing?
I understand where you're going down the path of, I think this kind of question would probably best if this was another 12 months down the track. And
I'm sure we'll be able to have the opportunity to do so. In fact,
I'm sure if we're sitting here in 12 months' time, my answer would probably slightly different. But let's give them the time to see how those actions take place.
Yeah.
Did you have a question?
Just a quick one. Sure. Thank you, through you, Chair. Very interested to hear that example about the CTO and how the police are injected into the whole process, so to speak, at such a base level, which got me thinking that if we take, and forgive me for what probably is going to be obviously my ignorance, but obviously through the 000 contact to the police, that is, or that would be a basis upon which police would find themselves often, that would be a not unusual means through which police find themselves turning up to a situation where there is a mental health dimension to it. Is that a fair statement?
Yeah.
It's through the AAA.
Yes.
So if I could just set that aside for the moment and look at the example that you gave very helpfully of the CTO, and I think there was another 1 or 2 examples you've given, which are not necessarily through the 000, but where there's a default of involving the New South Wales Police Force, the CTO, scheduling and what have you. Has a police association lined up, or perhaps this is a question on notice I'll put, where you've been able to line up all of these activities, if I could describe it that way, which form as a total work in the area where there might be mental health dimensions to it, to sort of help scope out all of these areas? Because when you it would be true to say that if you aggregate the 000 involvement of the police and all these others, that really becomes the universal, the universe of the issue, is it not, for the New South Wales Police Force? Is that right?
The Productivity Commission themselves reported that 10% of police time is spent responding to mental health.
10%, right?
10%. Wow. But that, I believe, would be under. I believe that that's recorded incidents. I wouldn't be surprised if it was double that.
No, okay, I think that's a good reference. I'll have a look at that. That's helpful. The other thing I was going to ask is, and it's going back to the 000, that and once again, showing my ignorance, the phone call comes through to 000 to the police. The person answering the 000 call for the police, do they have any expertise, or what is it, perhaps a better way of putting it, what is their level of expertise of engaging with the person who's putting the call through to establish whether this is a mental health issue or not, potentially, or is there, I guess, protocol to, if in doubt, default that it potentially might be and involve the police?
Quite often the response that is recorded by the VKG operator to be transported to the police officer is reliant on who calls.
Right.
Now, if it's a member of the public, if it's a neighbour, then obviously the information that you are going to get is going to be limited in regards as to whether it's a mental health incident. If a person is in their house yelling and screaming, that's all that person has. Now, if it's a friend or relative who has intimate knowledge of this person, I can see where you're going, kind of, in that a VKG operator may, in the future, have the option to say, have you contacted the doctor? Have you contacted the mental health crisis team? But police are caring people. At the moment, police are caring.
Yeah.
Well, at the moment, we go to everything. It would come across as a concern for welfare. Irregardless of what the content of the information is, we would attend.
Can I say outwardly that, and it might be controversial, but police officers, police organisation are so risk averse about now being criticised by the coroner, by a range of different people, the LEC and others, that failure to respond directly to an incident would see criticism in some shape, manner or form. Until guidelines and black and white are put in place, people have lost the urge to try and say, hang on, this isn't right. I will just do what the policies and the procedures do, and these organisations that are there to look over, and they've got their job to do. We are not here criticising the LEC or the coroner or others, but you've got to understand a byproduct of so many recommendations about so many things. People, human beings, will then revert back to, that's what the steps say, and that's what I have to do, because if I go one divergence from it, if I use initiative,
Yeah.
and say, hang on, this isn't a police matter, why don't I ring the local health team or whatever? If that's not on there, then they won't do it. So I understand where you're coming from, but 000, and especially in the bush, especially in the bush, I say, that there's no one else to ring anyway. We try, and we're trying our best, but at least we try. So many others, especially after 5 p.m. and before 7 or 8, there's no one else trying. There is no one else trying.
Yeah, but that's what actually my line of questioning was to go to get to that, and that's why I guess the UK model review will be interesting, because there will need to be some certainty around the parameters of it going one way or the other, which is in a sense a triaging exercise, isn't it? A decision point to be made about whether a mental health team, so to speak, is sent in to deal with a matter versus the police or both. And to make that work and work effectively, particularly in a state, as you say, New South Wales, with its resources and in some instances very limited resources on the ground in isolated and remote areas, it is going to be a challenge. But understand that UK model will be obviously quite instructive. And my only other question was, and we're going to hear about that obviously because there's been some senior representatives from the police force sent over. Are there any other jurisdictions in the world beyond the UK that you've become aware of that might be worth having a look at? I'm not suggesting we've got the power to...
Well, the UK model actually started some 2 years prior in Scotland.
Right.
But in regards to any other models of a suitable... And let me make this quite clear, that the UK model is quite controversial. And I'll read to you. It says, to the end, it is to govern the inappropriate and unavoidable involvement of police in responding to incidents involving mental health needs. That is their mantra. And they have a tiered process to determine what response police will have.
That's what I guess getting at, yeah.
Yeah, but I say that we live in a great country. No matter what resources we have, and no matter who does it, this country is so far ahead because in so many others, they believe that if you've got a weapon or that, then that doesn't matter whether you're 10 years of age or 90, you suffer from a mental illness or otherwise, you're breaking the law and consequences are the consequences. They don't care. And I feel proud to be in front of this committee here today and talking about in this country how that we can better serve our your constituents and our members and the people of New South Wales, because in Australia that's what we do. We look for ways forward.
No.
Thank you. We're out of time for this session. Thank you both so much for the time you've taken to provide evidence today, and the Secretariat will be in contact with you if there are questions on notice.
Thank you very much for the opportunity.
Pass on our thanks to the members who do wonderful work.
Thank you.
Thank you.
Thank you.
Good afternoon.
Welcome. Thank you for making the time to give evidence today. Could you please state your name and position title and take either the oath or the affirmation?
I'll take the affirmation. I'm Magistrate Carolyn Huntsman, but I'm here as the President of the Mental Health Review Tribunal. I'm on leave from the local court, so I'm not speaking for the local court, I'm speaking for the tribunal. I'll take the affirmation. Is it in? Oh, here it is. Thanks. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Would you like to make a short opening statement?
I'll make it quite short. You've got my written submission, so I'm just going to highlight a few points from that. The first thing is to underscore that the tribunal is not a service provider, so I cannot speak for that perspective. I respect that you will hear from people much more qualified to answer questions about service provision and resourcing. So I don't presume to be able to answer questions in that space. Why we did a submission, I think, was because community treatment orders are a huge part of the tribunal's caseload. And given that legal role, we thought it might be helpful to provide a bit of background about how CTOs work. That's why there's quite a lot of legal material in my submission, because that's where we come from. We're a legal decision-making tribunal. So we are an independent specialist tribunal under the Mental Health Act, and we have a civil division and a forensic division. The forensic division deals with people who have an intersection with the criminal justice system and the criminal courts, either because there's a verdict of act proven not criminally responsible or because they're found unfit to plead. And there's a whole complicated court process which sees them become forensic patients. We do make community treatment orders for forensic patients in the forensic division in two ways. They have two purposes. One is to provide treatment within the custodial facility under that order and under that treatment plan. And the other is that they're often applied for when someone's about to transition to community, either on parole, they're finishing their sentence, or maybe bail is possible. So there's a very important transition role, and it can be very helpful to have a forensic community treatment order in place when people leave custodial facilities. And so they're the two divisions. And the civil division, that is all the people who are not involved with criminal court orders. And that will see a lot of involuntary patients who are detained in mental health facilities for assessment and or treatment under involuntary patient orders. They will be discharged by the hospital, sometimes by the tribunal at a hearing, and sometimes they're discharged on a community treatment order from an inpatient admission. Community treatment orders are also made from the community by community mental health teams. Sometimes they're for people on existing orders. A further order is applied for. Sometimes it's a new application for someone that perhaps is looking at a need for more intensive interaction and the backing of a legal order. So it's important that the tribunal acknowledge in making this submission that we engage with consumers who are presented for treatment orders. So that's only 1% of what your committee will be looking at, because there's of course a number of people engaged in treatment in the community who don't have the backdrop of a legal order. So we see, I guess, a subset, and perhaps more acutely, people with more acute or more chronic mental health conditions are often the people that come before the tribunal. What we do know and what we have seen over time is that there seems to be a real move to collaboration with consumers by community teams, to trying to have a recovery-oriented approach, and we have seen a cultural shift over time, which is a really positive thing. We've seen some amazing work by community teams in engaging with people who are quite unwell and trying to support them holistically for their treatment. One thing that cannot be underestimated is the importance of community engagement, community support, stable housing. Social isolation is counterproductive. So what we see is that people who are well engaged with either work, study, family, or hobbies and interests, pets too, who have those sort of engagements and responsibilities are better able to manage their mental health and to engage with the supports available. There is the nexus with substance use. It's marked in my experience. Often people who have not all mentally ill people, of course, have a substance use problem, but when both are present, it makes treatment, I think, more difficult. I've been asking, I came to this role about almost exactly 12 months ago. So I'm in the end of my first year. In my first year, I did go and visit a lot of facilities, and particularly I was interested to go out to regional New South Wales. And when I was out in Orange for some of the forensic hearings at Bloomfield Hospital, I made a point of going out to Dubbo and meeting people there and seeing what the facilities there were like. This was mostly the inpatient facilities, but they gave me a bit of an overview of some of their challenges in the terms of the very wide geographical region that they cover. I've just gone on much longer than I meant to. My apologies. I'm here for you to question. So what I would say, just in closing, is that social supports, housing supports, drug and alcohol rehabilitation, and individualised recovery planning between community care providers and those with a mental health condition are all major important matters.
Thank you very much for your statement. This is really valuable evidence as well as the written submission you've provided. I've got a question about your recommendation for further research. To be honest, it's quite distressing that there really isn't the broad evidence base from large studies to support or inform the
Yes.
use of community treatment orders, and I'm interested to know if the Mental Health Review Tribunal is actually involved in any such research. Have there ever been requests, for example, for de-identified data, or are you aware of any of that work actually happening?
Well, there has been work done in the forensic space, and the researchers came in and went through our physical files. And we had to have a lot of protocols around that because there's a lot of confidential information and restrictions in the legislation against publication and identification of names and such matters. So there's quite a lot of work put into that. Some very good research came out of that. That was in the forensic space. The difficulty is that the tribunal has a very ancient database. One of my priorities since being appointed is to try and obtain funding to upgrade the database. It's facing critical failure. It's antiquated and cumbersome and cannot really be used helpfully. So if we get our new database, one of the ways we will want to design it is so that there can be statistics obtained for researchers to better inform everybody. We have a huge repository of potential statistical evidence, but we can't even access it. And the researchers who came had to go to the physical files. We're not digitalised, and there's a significant modernisation need that I've identified with my registrar. She's identified it too. She's very able in this space, and both of us are well ahead in looking at what will work, what interstate tribunals have used, what is available. And once we have that, we would be very keen to have researchers visit us and to be able to assist them in that regard. I do know the Mental Health Commission is doing something on community treatment orders at the moment, and one of the tribunal senior team members of the civil team is participating in that, group associated with that. I'll be very interested to see what they come up with. But to answer your question, there's not a lot of qualitative or quantitative research in the area. What we do know is, only from our experience as a tribunal, community treatment orders can be very effective in keeping people well. At the same time, one would hope that there would be transition to voluntary engagement rather than legal orders. Clinicians will tell you why they think some people need legal orders as a backdrop. The problems are the treatment plans are mandated in the orders, and if they're individualised and worked with cooperatively with the consumer, that makes I think the whole thing more easy and acceptable. But where the consumers feel a lack of choice, I think it can be a very difficult experience to be on a legal order.
I'm interested in understanding from your 2022 annual report, there was an 18% of increase in the number of individuals being considered for community treatment orders, and I understand a smaller increase, but an increase nonetheless in orders being granted. Given your answer about the dearth of research, I understand that this I'm probably asking for your opinion, but do you have any understanding of what's happening, why we're seeing that increase?
There could be. One reason could be, and I don't know, shorter hospital stays, because when someone is going to be discharged perhaps a bit early, you might place a community treatment order as the least restrictive care option on discharging someone. So a lot of people get discharged from early in the admission at a mental health inquiry, and the tribunal might make a community treatment order that the hospital asks us to make on discharge. So I don't know the correlation between length of hospital stay and community treatment orders. I don't know the correlation between difficult substance abuse and relapsing mental health conditions, and whether that is seeing an increase of community treatment orders. I really don't know. The people that are presented by the community teams seem to be not any changed to previous years, so I really can't comment, I'm sorry.
Thank you. Questions from the committee? Ms.
Thanks, Chair. Thank you, Magistrate Huntsman, for appearing today. It's been very, very useful so far. In terms of the, you mentioned the need to digitise the database for the tribunal and your awareness of what other states are doing. I wondered if you could talk us through what some other states are doing and how we in New South Wales could perhaps do things better.
Well, probably the most instructive experience I had was with Queensland, because they've basically modernised their tribunal in 5 years. So I've seen it 5 years after they started. They have very efficient AVL and in-person hearings. They have good AVL technology and good hearing rooms at their head office. They have modular member training, which is part of the website and data on their website and in their tribunal. So members can access a great range of information, and there's very active professional development by these monthly modular webinars. They have digital orders. So except for the typed orders that we do in the forensic division, in the civil division, our orders are handwritten on a typed form. So it's much more efficient and saves a lot of time to be able to have all of these processed. We don't even have, we haven't even digitalised the paper files. We need a project to do that. So the current registrar arrived and COVID started. So she's keen to get all of this done. And first thing she had to do was put in place a lot of extra equipment so that we could do remote hearings during COVID. And she was lucky she has such a good technology background that she was able to nimbly move. So I'm very guided by her in terms of the digital questions, and what she's told me is she needs to digitalise the records, and she needs to be able to create efficient orders and systems by having really good websites. So there are court data case management systems that are provided by different IT providers, and there are tribunal ones. So NCAT has a certain system here in New South Wales. South Australia has a very good system for its tribunals, which is a different case management system. And Queensland has another one again. But it just needs to be fit for purpose, and you can just so increase your efficiency, but also, you know, for the healthcare agencies and the hospitals, for them to be able to upload their documents really simply onto our website, like a really efficient document portal, as well as access our orders really easily, that would save them so much time.
So it would save healthcare workers in the hospital time.
Yeah.
Because you've gone to the next question about benefits and how this would...
Well, there's a tribunal clerk in most major hospital facilities who send through the list of patients. So every hearing list changes because the patients change. So we go to facilities in person because that, I think, is better whenever we can. But we also do some AVL hearings because some country regions there's not enough work in the day. You know, they might have a couple of patients in some of the smaller units in the regions. So we do a mix of both AVL and in-person. But the tribunal clerk has to send through all the medical reports and evidence to us, usually by email. Mm-hmm. Used to be by fax. Yeah. So in Queensland and other places, it's all much easier for the health facilities. So you'd save time and money in the health facilities, you'd save time and money in the tribunal, and you would arguably have a higher quality.
Yep, and the benefits would be to consumers.
Yeah.
a very different question now, if I may. In the submission, it talks about the CTT program.
Yes.
Which I know we've referred to already.
Yes.
I just wanted to understand, so 4 weeks post-release doesn't seem like a lot to me, but that's my rudimentary mind. And if we were, I note your submission also talks about the model of care and how that could be afforded to perhaps civil patients to achieve similar outcomes. What would that look like? And does the role of HASI and CLS, which I know you've already referred to, does HASI have a role to play in that regard for these civil patients, would you say?
HASI has a role to play for people that need wraparound supports of housing, case management, and, some home care visit type assistance. They often work in with NDIS, and there will be a service which might assist with shopping, cooking. So it's a very particular high-level support model. And there are levels of it, different levels of it, depending on the NDIS package and depending on the needs of the consumer and the kind of housing. There's many consumers that live with family. There are many that work and are independent, and they don't need that level of support. To get back to the CTT question, I'm happy to take some of that on notice and get back to you. But what I know about that transition is that it is intended that the community team take over from this transition team. So they'll be on a FCTO, a forensic CTO. That will all be, that transition team will help line up where they're going to be in the community, who's going to be the community healthcare agency. When they leave custody, a variation application will come to the tribunal, and we will have the new treatment plan for the community team, and we will vary the order so that it's no longer Justice Health implementing the CTO, but the community team is. So I think it's envisaged that the role stops and the community team steps in. And in terms of your question about leaving hospital care for civil patients, again, it would be a gradient. So someone who's had a very, very long and complex admission, and there are some lengthy admissions, might have lost a lot of their community engagement. So that population would probably go to HASI or community living. So that group could do with a transition team perhaps, but I think that's what inpatient facilities think they already have as well, and I'd be respectful of that. They're multidisciplinary inpatient facilities. There's a social worker, there's a discharge planning team, but some are less resourced than others, of course. And I know that in some facilities, sometimes, they're down a social worker or two and they're trying to recruit. So in those circumstances, it would be hard to have the depth of discharge planning. So I guess my answer is saying it's, again, specific on need and individual planning. But I could see a role for it because it's working so well in the custodial space. And it's relatively new.
Thank you.
Thank you. And could I invite Mr. Fang to ask a question?
Thank you. Thank you very much for appearing today. And just noting your earlier answers and comments, I'm just curious to know whether there might have been any money in the recently announced budget to improve the IT and back-end services of the tribunal, and if there's been any representations made to the Attorney General or the Minister for Mental Health, who I imagine would probably have oversight for those budgetary outlays, and how responsive they've been in order to provide you the increased budget that you clearly need in order to modernise the system.
All right. So I've met with the Minister for Mental Health. I've met with the Attorney General. They were very, they listened and were very supportive of the need to address this. I've met with the Mental Health Branch, who we sit under. So even though we're an independent tribunal, we do sit within the Mental Health Branch of the Department of Health.
And that'd be Minister Park, is that correct?
Yes.
Yes.
And also the Minister for Mental Health as well.
Yes.
So the mental health branch were supportive.
Mm-hmm.
They have funded a project officer
Mm-hmm.
so that we can get ready for procurement.
So is that effectively, essentially another review? Would that be, I guess, a review of the systems? Or?
No, I think it's to help us get to procurement.
Okay. And,
Yeah.
and the money's in the budget for the procurement of the system, or is it?
Not at this point.
Okay. Right. Okay. Thank you.
I just have one last question. I'm interested in your comments at paragraph 11 in your submission, where you're talking about that population, and you've touched on this before, with drug and alcohol problems and mental health problems. In terms of treatment and support for people with dual diagnosis, are there separate pathways that are needed? Is there a complementary pathway that's available? What are some of the challenges dealing with people with mental health and AOD issues?
My understanding, because I'm not a clinician, but my understanding is that substance use can lessen the impact of prescribed medication, so can be play a role in return of symptoms and relapse. So that's one issue. It depends on whether they need residential rehab and long-term treatment. I know that for methamphetamine, it can be very difficult to, if you've got an entrenched, long-standing substance use issue, it can be quite difficult to become abstinent. And so there probably is a need for residential rehabilitation, which addresses both mental health and substance use in the one facility. So it does both treatments, not separate. So I don't think there's a great deal in that space. And I know that it's very difficult to get into residential rehabilitation anyway. And when you have you're perhaps more difficult to manage because you're on prescribed medication and you have a mental health condition, maybe you'll find it harder to get a place. I don't know. I would not be surprised, just because there's a lack of places. Then there's people who can be assisted by not needing residential rehab, but by drug and alcohol counselling. Now, I can see them being co-located in the community and working together, and I think that already happens. The Merit program in the local court is an example of an intensive program that does actually achieve abstinence without residential rehabilitation. So, and again, it depends on the person, the severity of the substance use issue and their treatment needs. What I think needs to happen is there to be a variety of available programs. One size doesn't fit all.
And I gather from your submission you're concerned that there aren't enough AOD and mental health programs currently available?
Yeah, I mean, I can't speak completely for the sector, but over the years in various positions that I've had, I'm well aware that it can be very difficult to get a spot.
Great, thank you.
Yeah.
Thank you. Any last questions in the last 2 minutes?
Any questions, Greg?
Oh, okay.
Look, thank you very much for the time you've taken both to present today and to prepare the submission. It's really valuable evidence. We really appreciate it. And the Secretariat will be in contact if we have questions on notice.
Can I just say it's wonderful that you're doing this inquiry. It's the community. If you resource the community, that is where the success really is in treatment. So it's very good that you're doing this inquiry. I endorse the efforts you're putting into it, and thank you for your time.
Thank you very much.
Thank you.